Good afternoon, colleagues, ladies and gentlemen. I am Dr. Cheng from Peking Union Medical College Hospital in Beijing. And today, I'm very privileged and honored to be invited by Professor Herzelya, Professor Malaman, and also the organizing committee to have me here to have this presentation. And today, I'm going to talk about the importance of deep scleral lake based upon Chinese practice for class. And this is my financial disclosure. I'd like to thank the Ultima and also the Congo Pharmaceutical in funding me here in this conference, and also the great help in my glaucoma surgeries. So thanks for Dr. Nagy for introduction of the class surgery, so I can save 1 to 2 minutes. And we all know briefly about the procedures used in class to ablate the scleral lake and also the outer wall of Schlemm canal. And 3 years ago, class was firstly introduced to China, and it inspired great enthusiasm among glaucoma surgeons in China. But there is one challenge faced, that is anatomical feature is quite different, especially for the anterior segment, quite different for the East Asian people compared to the people from other regions. And also, the scarring issue is very severe for Chinese people. So this challenge brings to several questions to the surgeons in China. So with these questions, Chinese surgeons practice their pilot studies in over 20 cities in China. And the basic consensus is that the 6 months endpoint observation, the success rate, the complete success rate is around 60 to 75% for class procedure. And this is the result from my hospital with the 12 months endpoint. The IOP is around mid-teen. Considering about pre-operative super high IOP level, so it is still very promising for glaucoma patients. So, but there exists a huge difference among the different researchers, different practitioners in the success rate of class in China. So basically, it's probably due to the following issues, including the surgical site selection, preventive intervention, surgical procedures, and management of post-op IOP fluctuation. They are all not standardized. And also, there were lack of protocols. So they probably have different learning curve and different outcomes. So after 1 year practice, Chinese practitioners realized that the scleral flap, scleral lake, and Schlemm canal, the 3 key elements to know, and the position, correlation among 3 elements play important role in the final outcome of IOP for class surgery. So due to the limitation of time, today I'm going to focus about on the volume of the scleral lake, on the correlation between the lake and IOP lowering effect. So it is very rational to hypothesis that the volume of the lake will be very well correlated to the IOP outcome. But the answer is not such simple. It's just correct, but only on the early postoperative date. Within 1 month after the surgery, the scleral lake correlates very well with the IOP level. But in the long term, the existence of the scleral lake is rather than the volume of scleral lake play more important role in IOP control level. So in order to maintain the long-term scleral lake, we have to make the scleral lake enough in depth and enough in space during the operation. So here's the example. The 2 weeks after the class surgery, the IOP raises up to the 38 millimeter mercury. It is consistent with the diminishing of the scleral lake due to the insufficient ablation of the scleral lake intraoperatively. So in order to make the scleral lake for the long-standing intraoperatively, we recommend to use to do the scleral lake very deep with very thin scleral floor. You can see the pigmentation of the ciliary body and enough in size. So this scleral lake is about 4 and 2.2 millimeter in size. And for the challenging cases, I recommend here to do a more in size and more in-depth scleral lake. So this patient's size 4 and 2.6 millimeter in size, and even thinner of the scleral floor. And in order to furtherly facilitate the outflow of aqueous, you can add it on, creating a tunnel linking between the outer wall of Schlemm canal and the scleral lake. And TDW is also very important thing to say because it is vitally important, correlated very well on the IOP lowering outcome. And TDW basically had three advantages. First, it increased the size of percolation, of course. And second one, it's potentially increased the volume of scleral lake. And even more importantly, the TDW ablation facilitated the later on laser gonial puncture, which could further facilitate the outflow of aqueous. So this patient, you can see the laser gonial puncture applied after the well-established scleral lake. Although this patient, unfortunately, the IOP rises up over the first months after the surgery with from 7 to 31 millimeter mercury, and consistent with the impending closure of the scleral lake. But after the laser gonial puncture, we can say the scleral lake was reshaped and steadily maintained over a long time, consistent with the lowering controlled IOP level, which means if you create the very well-established scleral lake, it could be established like elastic, like sponge. So you can, after laser gonial puncture, the even impending closure scleral lake could be reformed over time. And for the narrow angle open angle glaucoma patients in China, we recommend strongly the LPI combined with ALPI perioperatively to prevent potential PAS or even iris incarceration. But the LPI should be made very peripheral and proper in size, like this patient. And then we can just move on the essence of the class. So basically, from the initial purpose and initial design of class surgery, we believe that hopefully this class surgery will be the easier or safer version for NPDS. But beyond that, we believe now the class surgery creates a new pathway through the suprachoroidal to make the surgery more safer for the refractive surgery patients. Let's read the example. So this is Beijing. I live there. And you can see during the rushing hour, the whole Beijing is like a parking lot. Do you know how many vehicles in Beijing now? 9 million. Okay, all right. So every day I have to crawling through this area to my hospital. But you can use another one through the subway. Still a lot of people, of course, but it could at least transport smoothly and get you there on time. So suprachoroidal pathway is a very good approach to prevent the superficial, very likely to fail the subconch pathway to create another way, because theoretically the inner the pathway is, the less fibrotic response will be, and will maintain the patient IOP for a long time. So finally, I'd like to add an example for this. So this patient is a 37-year-old male, and he was diagnosed as glaucoma secondary to active VKH. And this patient situation is very bad. His optic nerve head is paled and IOP is super high with 3 medications. When I met him, he already accepted 2 glaucoma surgeries for the left eye and CPC, and also failed. The IOP for the right eye is 39 and for the left one is 48 with 3 medications. Bleb is flat, corneal edema, and the vision is poor. So this patient, unfortunately, this patient, in order to furtherly control the IOP level, he just by himself took the oral methylzolomet. And then this medication led to the acute dermal lysis. And this patient then transferred to the emergency. And then this is the patient after the emergency restoration and just moved back from the emergency to our department. And then but the IOP is still super high, so we have to face these eye problems to applied surgery. So we can see, apparently, you can see the lysis of the conjunctival fibrosis, hyperemia of the conjunctival and the bleb, filled bleb area. And you can also see the sunset glow appearance of fundus. And this is a very challenging case. So basically, we just reopened the conjunctiva. It is not healthy. And then we recreated the flap, but it is also not healthy, we can see over here. And then we created the scleral lake using carbon dioxide laser and combined with the trabeculolectomy to have bi-pathway drainage for this patient. Hopefully thank you, and hopefully it works over time. So this is 12 months after the surgery, so his visual acuity remains stabilized and maintained. It's very good for him. And IOP is maintained for 10 millimeter for the right eye and left for the 18 millimeter with 2 medications. So this is quite acceptable for this patient. And then finally, in summary, I'd like to say modification and standardization of the class may improve the efficacy, and scleral lake should be made enough in depth and enough in space. Class may be potentially applicable for refractory glaucomas. And thank you for your attention.
Opening your eyes to ophthalmic innovation.